Bismillahirrahmanirrahim. Today is 12th May 2018 and I'm doing this recording for the medical students and my fellow doctors. So today's topic is neurodevelopmental disorders and child mental health. And my name is Dr. Kamran Shaikh. I'm a specialist registrar in the National Health Service. So when we come to child psychiatry, we have to see what type of disorders are there. Some disorders are of the nature that they are very, very similar to the adult mental health disorders, and some disorders are of developmental type which originate in childhood, while a third category of disorders is emotional and behavioral disorders with onset in childhood. Adult ADHD, attention deficit hyperactivity disorder, conduct disorder, and oppositional defiant disorder. So when oppositional defiant disorder and conduct disorder, they go into adulthood, some of them may progress as either emotionally unstable personality disorder, or otherwise they can progress as the antisocial personality disorder. Now, when you come to any disorder and if you're describing, you have to know what's the epidemiology and you have to bear these headings in mind. Epidemiology, the symptoms, the course, the symptoms, the diagnosis, differential diagnosis, and comorbidities. Etiological factors, biological, psychological, and social. Investigations, biological, psychological, social. Treatment, biological, psychological, and social, while taking care the multidisciplinary team, families, care planning, and taking the carer into account. And finally, the prognosis and follow-up. Now, the different disorders of adult type which have their origin in childhood. Number one is schizophrenia. So it's not much different from adults. Then comes depression. Depression is not much different from adults as well. However, in the childhood depression, anuresis and encopresis can occur. Means that they can wet their beds at night. Parental conflicts and bullying and emotional, physical, and sexual abuse can be there in the etiology of depression. And the treatment is cognitive behavioral therapy and SSRIs, especially fluoxetine. There's a point to bear in the mind that the SSRIs can increase the suicidality in the short term. Therefore, when you start SSRIs, monitor and follow up the child very, very closely in the child and adolescent mental health services outpatients clinic, and alert the family that there can be a transient increase in suicidality because the energy comes back while the thoughts improve later on. So the energy symptoms improve first and the thought symptoms and the suicidal ideations go away at a later stage. Eventually, the SSRIs reduce the suicidality. Now, the bipolar affective disorder, it's much less common in children. The treatment is similar to adults. The other disorders, obsessive compulsive disorders, it's very similar to the adults. However, obsessional fears, especially about the safety of loved ones, are very common. Treatment is also as for adults. Eating disorders, sometimes they have origin in their childhood, and sometimes the childhood eating disorders are extremely or can be extremely difficult to treat. And the personality disorders and learning disabilities, it's beyond the scope of today's discussion. School refusal can be another thing that can be an underlying cause or a comorbidity, and that should be treated. It is different from truancy because in truancy, the child goes to the school but disappears from the school, and it is primarily behavioral. However, school refusal is mainly because of the anxiety, stress, and depression. Now we come to the disorders of psychological development, and that is our today's main topic. So F80 to 89, and especially F84 to 89, we'll be discussing today. So F80 is speech and language disorders. F81 is also scholastic skills disorder, developmental disorder, for example, calculation difficulty, and then similarly 82 and 83. F84 is childhood autism, and this is what we are going to discuss today. So F84.1 is atypical autism, and atypicality in autism may be due to the age of onset or because of the symptomatology. Or atypicality can be both in age of onset and symptomatology. Then Rett syndrome, childhood disintegrative disorder, overactive disorder associated with intellectual disability and stereotype movements. And then F84.5 in the ICD-10 classification is Asperger syndrome. Then other pervasive developmental disorder, and then very important pervasive developmental disorder unspecified, which is F84.9. And we also call this in the DSM-5 as PDD-NOS, or pervasive developmental disorder not otherwise specified. F88 is other disorders, and F89 is unspecified disorder of psychological development. Pervasive developmental disorders. So a group of disorders characterized by qualitative abnormalities in reciprocal social interactions. So that's the first thing. And it's the same as autism, autistic spectrum disorder, Asperger syndrome. The theme is the same, that there will be abnormalities in three domains. Number one, reciprocal social interaction, that the child is not socially interacting with the peers, with the adults, with colleagues, with the fellows, or with friends, or with anyone. The number two, patterns of communication. The child is not communicating in a healthy way. For example, the child is not talking, not making gestures, not making use of appropriate facial expressions. And similarly, the play is also not conveying anything. For example, lining up the toys or the blocks instead of making a castle, etc. The third problem is in restricted, stereotyped, repetitive repertoire of interests and activities. That means the child is doing something again and again and again. For example, the child spends whole day on computer, or whole day on lining up the toys, or whole day in doing one and the only thing. The child gets very, very disturbed if his or her routine is disturbed, or if the environment is disturbed. if his things are rearranged, he gets extremely upset. And this behavior arises before a certain age, which is usually before the age 3, and it is pervasive in all situations. So, epidemiology of autism spectrum disorders. Autism, the prevalence of autism is 20 in 10,000. Asperger syndrome, it is 6 in 10,000. And Rett syndrome, 1 in 10,000. Childhood disintegrated disorder, 2 in 100,000. And atypical autism, 37 in 10,000. So if we combine the autism, Asperger syndrome, and the atypical autism, it goes approximately around 60 in 10,000 if we combine everything, atypical autism and Asperger syndrome and autism. Childhood autism, a type of pervasive disorder, developmental disorder that is defined by the presence of abnormal or impaired development that is manifest before the age of 3 years. That's what we were describing earlier, that it arises before the 3 years. So before the 3 years, either the parents take notice, or at a later stage they realize that the child did not make appropriate social interaction or communication even before the age of 3 years, and was doing the same thing again and again and again even before the age of 3 years. The characteristic types of abnormal functioning in all the 3 areas of psychopathology is there. So reciprocal social interaction, communication, and restricted, stereotyped, repetitive behaviors. And then a range of other non-specific problems are common. For example, phobias, sleeping and eating disturbances, temper tantrums, self-directed aggression, sensitivities to noise, sensitivity to light, and sensitivity to change in environment or change in routine. Atypical autism. Atypical autism, as I said earlier on, that it can be different from the autism, as the age of onset may not be exactly 3 years or earlier than 3 years. So it may be after age 3 years. The symptoms arose after 3 years of age. That will make the autism atypical. Or otherwise, failing to fulfill all 3 sets of diagnostic criteria. For example, if abnormal and impaired development is present, but a lack of sufficient demonstrable abnormalities in 1 or 2 or 3 areas of psychopathology required for the diagnosis of autism are not there. So it is a lack of psychopathology, or the psychopathology is not there, and that psychopathology is namely reciprocal and social interactions, communication, and restricted stereotype repetitive behavior. In spite of characteristic abnormalities in the other areas. Now, what is autism? So autism, we said that the IQ should be low. If the IQ is normal, we'll call it as high functioning autism. But if the IQ is low, we call it as autism or autistic or childhood autism. So in childhood autism, the IQ is low, there is an impaired and delayed speech. However, in the high functioning autism, the speech may be delayed or may not be delayed, but the IQ should be normal in high functioning autism. So IQ normal, high functioning autism, and that is according to the DSM-5. So high functioning autism with impaired speech, or high functioning autism with normal speech. And there is no such term as Asperger syndrome in the DSM-5 classification. Now, the etiology of autistic spectrum disorders. In the etiology or causology, it can be genetic because the condition is 50 times more frequent in the siblings of affective individuals than in the general population. Heritability of 80 to 90%, and high monozygotic concordance. There could be obstetric complications, could be family history, comorbid learning disability due to any cause or any unknown cause, epilepsy, head injury, an infection during infancy or in utero can contribute to the developmental disorders. Complications during pregnancy, maternal smoking during pregnancy. Now, this is more linked to the ADHD, but not with autism. But all other things can cause both ADHD and the autistic spectrum disorder. Similarly, maternal drug and alcohol use, it can contribute to both. Brain abnormalities can cause both ADHD or ASD. Structural brain studies have established that autistic children have larger brain volumes than normal children. And functional MRI scanning has provided evidence for aberrant functional connectivity in the neural circuitry that supports social cognition and theory of mind. There is an impairment of frontal lobe function, executive functions involved in the planning and organization are also impaired, and there is a lack of theory of mind. So that's the etiology in a nutshell. Now, the differential diagnosis and comorbidities, as we said earlier, that we should make headings including epidemiology, symptoms, etiology, differential diagnosis, comorbidities, investigations, treatment, prognosis, etc. So, the differential diagnosis of comorbidities of autistic spectrum disorder and ADHD, they're very similar. So, in the case of autistic spectrum disorder, the first thing which comes to the parent's mind is the child deaf? Because the child is not communicating, the child is not responding, the child is aloof. And it can be excluded by appropriate hearing tests. Then the communication disorders, for example, expressive language disorder or receptive language disorder. In that case, if the child is not communicating with words or not understanding words, the child should be able to understand the gestures or the nonverbal communication. What happens in the autistic spectrum disorder that the child is not grasping any verbal or nonverbal communication. However, the hearing tests are normal. And how do we know that the hearing test is normal? The child will respond to what is interesting to him. For example, he will respond to the nursery rhymes, or he will respond to the sound he likes. Now, the learning disability can be comorbid in both ASD and ADHD, that's autistic spectrum disorder and ADHD. Challenging behavior can be there mainly in autistic spectrum disorder. And then in ASD, ADHD is the most common comorbidity. And similarly, in ADHD, autistic spectrum disorder can be one of the comorbidities. Tic disorder or Tourette syndrome can be a comorbidity or can come in the differential diagnosis. Depression can occur in both groups. Psychotic disorders can occur, especially in adulthood or early adulthood or adolescence. Obsession, the oppositional defiant disorder, conduct disorder, attachment disorder, they can be comorbid with ADHD or they may come in the differential diagnosis of ADHD. And in that case, it may continue as an emotionally unstable borderline personality disorder or as an antisocial personality disorder. So it's important to rule out. And last but not the least, sometimes in the adolescence, some of the adolescent children with ADHD may go to develop substance use. Now we are still on to the autistic spectrum disorders and the course and prognosis of autistic spectrum disorder. So 10 to 20% of children improve between the ages 4 to 6 to a certain degrees to enable to attend an ordinary school and obtain work. A further 10 to 20% can live at home but cannot work and need to attend a special school or training center and remain dependent on their families or support services. The remainder, at least 60%, improve very little and lead a dependent life, and many require long term residential care. Those who improve may continue to show language problems, emotional coldness, and odd behavior. The good prognostic factors for improvement in autism or autistic spectrum disorders is a higher IQ and a good communicative speech by the age of 6. Now, what investigations we do? So the investigations can be for the core disorder or it can be to determine the comorbid intellectual disability or to measure the intellectual function, which may even be a very high intellectual function, may even be higher than normal in high functioning autism or the Asperger syndrome. So the intelligence tests we use is Stanford Binet test, and that is one of the most commonly used in the Republic of Ireland. Similarly, Wechsler Intelligence Scale, WISC-3, it's worldwide used for the diagnosis of intellectual disability. And Wechsler Preschool and Primary Scale of Intelligence British Ability Scales. So that's used in preschool children. And then this is the intelligence tests. And other psychological tests are social developmental assessment tests, for example, Vineland and Bailey scales, and other developmental assessment, Denver Developmental Screening Test. And then there are educational attainment tests, Neal analysis of reading tests, Shonell graded word reading tests, Shonell graded word spelling test, and tests of mathematical ability. Now, the other investigations, especially for the core symptoms of autistic spectrum disorder and to rule out the other comorbidities and differential diagnosis. So the hearing test is the first one because that's the first concern of the parents. Is the child deaf? The second is developmental history. So take a thorough developmental history and then autistic spectrum disorder observation schedule or ADOS or autism diagnostic observation schedule is the right term for that, in which the child plays in a controlled, supervised environment in a very, very structured way and guided way, and different tests and different tasks are guided by the administrator of the ADOS test. And child is measured on all three different domains, for example, stereotyped activities, communication, and socialization. In this test, the ADOS, the child have to be present inside the clinic and inside the room, or otherwise the equipment can be brought to the child's home. However, there is another test called ADIR, Autistic Spectrum Disorder, or Autism, uh, uh, Autism Diagnostic Interview Revised. So ADIR stands for Autism Diagnostic Interview Revised. And you take a structured, very, very structured and sophisticated interview, systematized interview with the child's parents. Then school observation and home observation is another thing. And imaging can be done, but it's mainly for research purposes because it will tell you about the brain volume or hippocampus or hippocampal volume, etc. Now, the treatment of autism, the core symptoms, is only by or mainly via psychoeducation and parental training. So the parents understand what is wrong with their child and adopt their attitudes towards the child. And that reduces the uh, stress levels in the parents. Then parental training is again on the psychoeducation lines and also on the lines that how to do the behavioral therapy of the child. So the parents become the therapists, but they and the parents attend the classes that how to tackle with the child's challenging behavior and how to manage that and how to cope with the child's condition. Then contingency management of challenging behavior. Again, very similarly, to positively reinforce the desired behavior and to negatively reinforce the undesired behavior so that the desired behavior is more promoted. And then a very important part is how we treat the child, because in the first three examples, the parents are doing something, but how the system can do something is providing additional resources at school, for example, special needs assistants, resource hours, special schooling is another very, very important. And sometimes when the non pharmacological measures fail about tackling and controlling the challenging behavior of the child, what we do is that we provide the drug treatment for challenging behavior. And that drug treatment is mainly very, very low dose antipsychotics, such as risperidone or aripiprazole. And then obsessive compulsive disorder and depression can be treated with small doses of antidepressants. Similarly, tics can be treated with low dose antipsychotics or clonidine, and ADHD can be treated with stimulants or atomoxetine. Family support is very, very important, and respite houses. For example, if the parents have to go somewhere else and they find child's behavior very, very difficult, or they want a break of 1 or 2 days a week or a month, they can send the child to a respite house for a day or two. Individual psychotherapy, it can work in the adolescents, and then the family therapy if there are disturbance in family dynamics. And then there could be different organization, for example, Aspire in Ireland, and then there could be different other organization. Now, the tic disorders. Tics are involuntary, rapid, recurrent, non-rhythmic motor movements, which are usually involving the circumscribed muscle groups, or vocal production that is of sudden onset and serves no apparent purpose. So there can be common simple motor tics, for example, eye blinking and neck jerking. So it could be motor tics. Then there could be common simple vocal tics. So simple and vocal. For example, throat clearing, barking, sniffing, or hissing. Then there could be complex tics. For example, common complex motor tics such as hitting oneself or jumping or hopping. Common complex vocal tics, for example, repetition of particular words or use of bad or often obscene words. And then Tourette syndrome, in which there are combined vocal and multiple motor tic disorder, at least for more than a year. The treatment is generally with habit reversal, mask negative practice, or medications such as risperidone and clonidine or guanfacine. ADHD medications can worsen the tics. Therefore, if the child is already having tics, we should ideally avoid giving methylphenidate or atomoxetine. And sometimes it is a side effect of the atomoxetine and methylphenidate that it can even produce the tics in a child who never had the tics before. The next one is hyperkinetic disorders or ADHD, and that is today's one of the focuses. So hyperkinetic disorder as per DSM-5, and we will go through the DSM-5 criteria for this because it is revised in 2013, whereas the ICD-10 criteria dates back to 1992. So in the DSM-5 medical classification, they say that for children, 6 or more of the symptoms table have they will show a table that have persisted for at least 6 months to a degree that is inconsistent for a developmental level and negatively impacts directly on social and academic or occupational activities. So there have to be 6 or more symptoms which have to be there for 6 months. So the rule of 6 symptoms and 6 months. And for older adolescents and adults, there could be 5 or more symptoms at least, which should be there. And which kind of symptoms will be there? That the 6 or more symptoms. There could be symptoms of inattention or hyperactivity hyperactivity impulsive type before the age of 12 years. Now, previously in the ICD-10, they say 6 years or 7 years, and the previous DSM-4 also said 7 years. Now they have doubled the age range and it is 12 years. So the even if an 11-year-old child comes with the symptoms of inattention and hyperactivity, they will diagnose him and treat him with the anti-ADHD medications. The second thing is that it's not only the age. The child should be hyperactive plus inattentive or impulsive in different settings, that is, a school setting and a home setting. So in both the settings, if the child is hyperactive and impulsive and inattentive, then we can say, and it's for at least 6 months, and the child's age is less than 12 years. In that case, we can say the child may have ADHD and we can investigate him further. So there could be a clear evidence that the symptoms interfere with the reduce the quality of social, academic, or occupational functioning, and symptoms do not occur exclusively during the course of schizophrenia or any other antipsychotic disorder or mood disorder. So the symptoms are primarily of inattention and hyperactivity and impulsivity, and they're not secondary to any adult type mental illness such as schizophrenia, psychosis, bipolar, or depression, etc. And this is a cartoon. So you can see the child is climbing, and that is one thing which the parents find it very, very difficult to handle. Now, what are the symptoms? Because they say that at least 6 symptoms should be there. So, what are the symptoms? So, the symptoms of inattention are there. For example, if often fails to give close attention, so they make careless mistakes, they do not attend, they have difficulty sustaining attention in tasks or activities. So, the first of all, inattention symptoms, they are not paying any attention. That's number one. Number two is that they are making multiple mistakes. So if you see the diary or a notebook of a child with ADHD, it's full of mistakes and scribbling. And then the next is they have difficulty sustaining attention in tasks or activities. They often do not seem to listen when spoken to directly. That's another thing which happen in ADHD individuals. Then the next is that often does not follow through on instruction and fails to finish schoolwork or workplace duties. So they're not follow through on instructions. First of all, they're not listening. And the second is they're not if they're listening, they're not following through on the instructions and they fail to finish the schoolwork or workplace duties. And that is usually at the school, or otherwise, if they come at home, they fail to accomplish the homework. They often have difficulty organizing tasks and activities, and this symptoms is very important in diagnosing the adult ADHD because they may listen or they may apparently listen, they may follow through on the instructions, but they may have difficulty organizing themselves. They may come late or they may be quite disorganized or living in an unclean or disorganized environment at home. The next thing is often avoids or dislikes or is reluctant to engage in the tasks that required sustained mental effort. That means that if the child is paying more attention to the subject he likes, for example, he likes the mathematics, and he will pay more attention to the mathematics part, but he may not like the Irish language or the English language or the social studies, and he may hate the subject and he may not pay any attention to the subject. They may often lose things necessary for tasks or activities. So, losing things can be another problem. And they are sometimes easily distracted by extraneous stimuli. So, if a tractor is passing by, or if an aeroplane is passing by, or they see anything outside the window or within the room, or a fly or mosquito or anything or any noise from outside, they can get distracted very, very easily. And they are often very forgetful in daily activities. So they may forget what you have told them 2 or 3 minutes ago. These are the symptoms of inattention. Now, in the second column, we can see the symptoms of hyperactivity and impulsivity. Previously, the diagnosticians used to separate out the hyperactive symptoms and impulsive symptoms, but now they have combined them in a spectrum in the DSM-5, and I think that's a good thing because they are in the same spectrum and they have the same theme. Hyperactivity and impulsivity, they are quite directly proportional to each other and they overlap with each other a lot. So, what are the symptoms of hyperactivity and impulsivity? The children often fidget with or tap hands or feet, and they squirm in the seats, and they often leave seat in the situation where remaining seated is expected. They often run or climb in situation where it is inappropriate. In adolescents or adults may be limited to feeling restless. So fidgeting, leaving seat, and running and climbing. And then they're unable to play or engage in leisure activities quietly. So they're speaking and they're talking and they're making noise. They're always on the go. So the child is always on the go. And in the DSM 5, they say as if they're driven by a motor. They often talk very excessively and they often blurt out answers before a question has been completed. Often they have difficulty waiting for their turn. So if they are playing a game or a sport which needs taking turns, they may not be very good at taking turns and may interfere or may intervene or may disturb others and just intrude into the play. That would be the right word. And finally, often interrupts and intrudes on others. So it's the same thing as waiting. If they are not waiting for their turn, they may even interrupt or intrude. Now, what is the etiology of the ADHD? We have discussed that many of the things are common with the ASD, and there are some additional things. For example, maternal smoking during the pregnancy and the family history. Family history is very, very important in all the childhood psychiatric disorders. And whenever you have to take a childhood psychiatric history, whether it's a short case or a long case or a real life clinical scenario, two things you must do. You must take a thorough developmental history and you must take a thorough family history as well. And it's not only the presence of disorder in the family, but also about the family dynamics. The epidemiology of the ADHD is that it is 1 to 2% in the UK and 5% in the United States. And we can see that there could be some more, either like it may be more diagnosed in the uh, United States because of the age limit that we can diagnose even after the age of 6. However, in the ICD-10, in the older classifications, we could not diagnose it after the age 6. Boys is to girls ratio is 2 is to 1. So again, like autism, it is more common in boys. However, in autism and Asperger's, it is 9 is to 1 or 4 is to 1, whereas in ADHD, it is 2 is to 1. Prognosis: 50% of the children have symptoms in adolescence, and 15% fulfill the diagnostic criteria at age 25, while 65% have some symptoms at the age of 25, according to the adduk.org. There is a strong association with alcohol and substance misuse and smoking because the nicotine is also a stimulating drug. And sometimes these individuals, if they're not treated properly and appropriately and promptly within their childhood, they start self medicating themselves, sometimes with the smoking and sometimes with the dangerous drugs such as cocaine or ecstasy. Now, the treatment for ADHD. So, treatment includes psychoeducation of the parents and parental training, very similarly as you do in the autistic spectrum disorders, family therapy if there are disturbed family dynamics, contingency management, that is positively reinforcing the desired behavior and putting some limits to the undesired behavior. And then the adjustments at school, such as less distractions, more movement breaks, and psychoeducation of the teachers so that they understand that the child has problems and they are more understanding and considerate towards the child. Social skills training can be done to the children so that they understand what is required and what's not required. And additional resources at school, such as special needs assistance, resource hours, etc. There are organizations such as ADD UK. And then, if the child requires a medication, which most of the children do require, then what will be the medications? So, the medications are either stimulants such as the methylphenidate and dexamphetamine. The mechanism of action is that they are NDRI, that is noradrenaline dopamine reuptake inhibitors. The dosing is that you give roughly 1 milligram per kilogram for methylphenidate. And there are different preparations available. For example, the simple methylphenidate Ritalin is the trade name. It comes in as a fast release, and you have to give it twice a day, once in the morning and once in the afternoon, but not generally in the evening because otherwise it will disturb the sleep of the child. Similarly, there will be long acting preparations such as Concerta or Medicanet or Ritalin LA, and that means that you give one preparation, one medication in the morning, and that will do for about 12 hours. And then after the end of the day, the child may be able to sleep properly. And then there are ultra long preparations such as lis dexamphetamine, and they will cover the time till the sleep. The only limitations is that all these medications can sometimes disturb the sleep. Duration, as long as it helps, you should continue the medication. So maybe until adolescence, and some people may require the stimulants or non-stimulant treatment in the adulthood as well. Drug holidays. So these stimulants are very fast acting. The moment you give stimulant, it controls the child's hyperactivity and it increases the attention span. But sometimes you don't, you feel that you don't need to the child to be very quiet and you want them to play, especially during the holidays, or you don't want the side effects every day except for the school days. You don't want any side effects, for example, the lack of appetite, the lack of sleep, lack of appetite can even halt the growth. So when this happens, you introduce the drug holidays. It is disputable that some people promote the drug holidays concept, that it should be given, and some people say that it's not ideal and the child should be given the medication even on the holidays. Now, the side effects can be growth retardation because of the appetite, and then cardiovascular symptoms, the pulse and the blood pressure can go high. And if the child has already got any heart problem, it can lead to arrhythmias. Therefore, it is very important that if the child has any heart problems, uh, consult the cardiologist, the pediatric cardiologist, before initiating any drug treatment. Sometimes it can be mood side effects, either elation or otherwise it could be depression. And depression, how it occurs, is that the child will be more attentive and more into himself, and he may realize that what's going on in his mind, and that may lead to a depression. Otherwise, it's not a direct side effect of the medication itself, and we don't see depression very much in this group. Liver can be affected, but it is more so with the next page drug, which is atomoxetine, but sometimes methylphenidate can also do. So it will be important to check the liver function test pre-hand if possible. And sleep can be affected, tics can be worsened. Follow up and monitoring. So you see the child when you initiate the medication, you titrate the dose, and you see the child every few weeks, every 3 months, and finally you see them in the ADHD clinic every 6 months once they are settled. And prognosis, we have already discussed that some of the children may go into the adult ADHD. Remember that adult ADHD also has its origins in childhood and at least before the age of 12. See, whenever you are dealing with adult ADHD, establish a timeline that the child developed ADHD before the age of 10. Now, the drug treatment of atomoxetine. Atomoxetine is a NARI, and so it's not methylphenidate and it's not dexamphetamine, and that's a typo. So you should, atomoxetine is a mechanism of action is that it is a NARI, noradrenaline and noradrenaline reuptake inhibitor, simple. That's it. And the dose is 1.2 milligram per kilogram. So it's roughly the same as the kilograms, whether it's methylphenidate and or whether it's the atomoxetine. So the child weighs about 20 kg weight, the methylphenidate will be about 20 milligrams, and the atomoxetine can be a little bit up to 25 milligrams. The duration, again, as long as it helps and as long as it is needed, and some people may need it in the adulthood. Drug holidays we have discussed, but in atomoxetine it's not generally recommended because it takes some time to build up in the system. And side effects very similar. However, it doesn't affect the sleep that much. Otherwise, pulse, blood pressure, liver, tic worsening, it's the same, and especially liver, it can affect. So it will be more important to check the liver function before starting atomoxetine. Follow up and monitoring, again, very, very similar to the methylphenidate, and prognosis is again the same. Other treatments for ADHD, clonidine, if there are comorbid tics, clonidine can be prescribed. However, it is generally prescribed either by pediatricians or pediatric neurologists. Risperidone can be prescribed if the child has comorbid autistic spectrum disorders and the child is not responding to either methylphenidate or atomoxetine. And so this is about the ADHD. There could be other disorders which we go through briefly. For example, elective mutism, in which the child is making interaction and making speech or speaking in one environment, for example home, but mute is in but is mute in another environment such as school, and not speaking at all in the school. It could be reactive attachment disorder of childhood, disinhibited attachment disorder of childhood, emotional disorders with the onset specific to childhood, separation anxiety disorder of childhood, phobias, social anxiety disorders, sibling rivalry disorder. And sometimes these phobic anxiety disorders can be comorbid with autism or autistic spectrum disorder, which is a very much a milder form of the conduct disorder in which the child is oppositional to the rules of the house and disobedient to the authority figures, but is not doing anything with the country laws. And then the learning disability. The mild learning disability is when the IQ is between 50 and 69. Moderate, it is 35 to 49. Severe, it is 20 to 34. And profound, it is less than 20 of the IQ. And there are various causes of intellectual disabilities. And sometimes we don't know about any cause of the intellectual disability. The most common causes are Down syndrome, Fragile X syndrome, and fetal alcohol syndrome. They are the known causes. And then amongst the unknown causes, we don't know what's happening. And that's all about today's presentation. Thank you very much for your time and for your listening.